Good afternoon, everyone. Welcome to the National Healthcare for the Homeless Council's first webinar in a three-part series, Increasing Access to COVID-19 Vaccines Among Homeless Populations, Successful Partnership Series. Today we are featuring Washington, D.C. and the wonderful collaboration between Unity Healthcare and the Department of Human Services. My name is Katie Lee. I will be your moderator today, and I am a member of the policy team at the Council, working specifically on COVID-19 projects. Just a few little housekeeping necessities. As you can see in front of you, this is supported through HRSA. And as a disclaimer, there are representatives from lots of organizations, and this webinar will be recorded, and the slides will be available, and the recording will be available after this webinar. So today we are joined by 4 wonderful members of the DC community. Dr. Catherine Crossland. She is the Director of Homeless Outreach Development at Unity Healthcare and the Medical Director for Emergency Response Sites during the COVID-19 pandemic. Her colleague, Dr. Colette Harris, who's a family physician at Healthcare for the Homeless program within Unity and Homeless Outreach. Dina Haslin, she is the Director of Policy and Program Support at the DC Department of Human Services. And Bill Kennan, Program Manager at the DC Department of Human Services. Just to lay out what the next hour is going to consist of, we are going to talk about, they're going to describe their collaboration between Unity Healthcare and Washington, D.C. Department of Human Services that began really in earnest at the start of the COVID-19 pandemic. We're going to hear from the healthcare providers who implemented COVID-19 vaccine education and administration events to people experiencing homelessness. We're going to hear some highlights of the amazing data coming out of DC and discuss lessons learned and strategies for long-term housing solutions. And our goal here is for this to be collaborative, so we are going to try and address as many of your questions or comments as possible. So please bear with me as I monitor the chat, and very grateful for my colleagues at the Council who are going to help me with that process. So just to set the stage a little bit for you all, what these panelists have shared with me is that their mission-driven instinct of their organizations is what has fostered this collaboration over the past almost 14 months. And the fact that when the needs of people experiencing homelessness needed to be addressed in the DC community, these 2 organizations came together to identify and operationalize a number of strategies to assure that people experiencing homelessness received the care necessary, both in an ongoing need for their ongoing health care, and then very specifically related to COVID-19 issues such as testing and ultimately vaccination. So join me. I'm going to start with Dr. Crossland as she introduces their partnership. And please enjoy, while she's speaking, some wonderful documentation of the work that they've been doing in picture form. Dr. Crossland?
Thank you so much, Katie. We are so happy to be here sharing our experience, and I really look forward to hearing about the experiences in Minnesota and Chicago in the next couple of weeks. I know today's webinar is really focused on partnerships as they relate to the vaccine rollout, but I thought it was worth taking a step back to give some context to the partnership between Unity Healthcare and DC's Department of Human Services since the beginning of the pandemic. Because the vaccine rollout is really just the latest chapter and perhaps the most hopeful chapter in the story. So Unity Healthcare, for those of you who don't know, was originally founded in 1985 as one of the country's first healthcare for the homeless projects. And since then, we've grown to become DC's largest federally qualified health center in DC, with community health centers in all 8 wards of the city, school-based health centers. We're in DC jail, and we also continue to have the Healthcare for the Homeless program, which is the largest medical program serving people experiencing homelessness in the city. And over the past few years, I've also had the privilege of serving as Unity's organizational representative at DC's Interagency Council on Homelessness, and have had the opportunity to provide clinical perspective in a wide-ranging policy issues across homelessness in DC. And so when the pandemic struck, Unity was positioned really as a natural partner to DC's Department of Human Services to develop effective responses to the pandemic. We also had relationships in place over years of kind of collaborating on a wide range of issues. And so it really was a natural partnership. As you all know, when the pandemic first struck, the guidance, public health guidance that was coming out of the CDC and also the Department of Health in DC really didn't apply to people experiencing homelessness. This concept of quarantining at home, especially if you were older or medically vulnerable, the idea of going home, staying at home and isolating if you had COVID concerning symptoms or COVID itself. And so really in the beginning, the Department of Human Services and Unity Healthcare came together really scrambling to come up with plans that would be effective for populations living in large congregate settings. And so like many places in the country, we developed non-congregate hotel shelters of two different varieties. The first being isolation and quarantine hotels, where people with COVID or with symptoms concerning for COVID or who were close contacts of somebody with COVID could go to either quarantine or isolate for a designated period of time so that they not only could take care of themselves, but also to protect the communities in which they lived, these large congregate shelters. At the same time, very early on, we thought about what's happening to our older medically vulnerable population, those folks who are the most at risk for developing complications or even dying from COVID. And so we developed non-congregate shelters in the form of hotels for this highly vulnerable population. And my colleague Dina Hassan is going to sort of go through those two programs for you and what they offered to our clients. But so from the beginning, we were not only creating these programs together, we were going to the shelters and screening folks for COVID symptoms. We were testing people both at the isolation and quarantine sites, but then eventually at the hotels, the protective hotels, doing site-wide testing to make sure that they stayed COVID-free. And then when the vaccine came around, finally, we were so grateful that the city prioritized people experiencing homelessness as a high priority group to get this vaccine. And so we have a colleague, that's actually a picture of me vaccinating a gentleman in his dorm. We set up these large tents outside the shelters, and this gentleman couldn't even walk out to the parking lot to get his vaccine. And so I went in and administered his vaccine in his bunk. But that's just sort of speaks to the partnership. We've always at Unity believed in treating our patients where they are. We have set up our clinics in shelters, in day centers, in food programs where they're already receiving other services. We've partnered with outreach workers in our street medicine program, and similarly in our efforts to roll out the vaccine, we've sort of capitalized on those existing clinics and partnerships to bring the vaccine to our patient population, and I would argue have done so pretty successfully. So I will, with that, turn it over to my colleague, Dina Hassan, to talk a little bit more about the programs that we were able to develop and then move into the actual vaccine. This is a picture of myself. I know that a lot of us really thought that it was important to show our patients that we trust the vaccine, we believe in it, we got the vaccine, and I was actually able to convince a number of my patients to get the vaccine through my confidence in the vaccine. And so that trust between patient and provider, peer outreach workers, et cetera, just cannot be underestimated. So I'll turn it over to Dina.
Thank you, Dr. Crosland. So Dr. Crosland gave a high-level overview of DC's bookended approach to serving persons that are experiencing homelessness in DC during the public health emergency. So this slide in front of you gives a pretty concise explanation of, from a programmatic sense, what our proactive stance was and what our reactive stance was or is. So Dr. Crosland mentioned our isolation and quarantine sites, which we call our ISEC sites. And those are for persons who have a positive COVID-19 diagnosis, have been in extended close contact with a positive case, or those that are arriving to DC from the areas that had a high COVID-19 prevalence before, who cannot safely isolate in a private residence. We do use hotels, and in those hotels, every client is placed in their own room. They receive daily medical wellness checks from Unity Healthcare, docs, and nurses. And clients normally stay between 10 and 14 days, and Dr. Crosland and her team constantly monitors CDC's best practices and guidances and other infectious disease leaders locally and nationally to understand what that length of time should be for isolation and quarantine. So that is our reactive approach. And then proactively, we want to make sure that those that are most at risk of severe COVID-related outcomes are protected as well. And that's our PEP-V program, or our Pandemic Emergency Program for Medically Vulnerable Individuals. It's a mouthful. Where we have clients in hotels. We do double occupancy, but if a client, because of health concerns, or if they need a little bit more space, or if they have concerns that make them less likely to be successful with another person, are placed in rooms. They receive housing case management because our goal is to make sure that while we have these clients with us, that we avail them to all the services that we can deliver to them. And we hope that as the clients leave our PEP-V sites, that they are connected, and we're working really, really diligently to make sure they're connected with a broad range of services, housing intervention services that are available to them via light touch services, which could be helping with rental arrears to lease up into an apartment, all the way to deep subsidies that come with permanent housing and permanent case management services. And then clients that are PEP-V right now stay on average around 160 days. It's a little short of like 5 or 6 months or so. And then regardless of ISEC or PEP-V, all sites have on-site medical and behavioral health services there for clients to access. And then all clients receive 3 meals a day and snacks and juices, etc. Next slide, please, Katie. So for the PEP-V program, we wanted to spend a little bit more time here because I think this is the program where we have the highest and longest engagement with our PEP-V program, and where we first launched our vaccination efforts for those experiencing homelessness. It's often because folks stay with us for such a long time, there's often confusion between PEP-V and our normal homeless intervention services. And we, every time we talk about PEP-V, we want to make sure that it's framed within the public health emergency context and not as a solution to ending homelessness permanently, unfortunately. It was established under the mayor's emergency powers. And like I said earlier, while the clients are with us, we try to deliver as many services as we can to them so that when they leave PEP-V, they leave with connections to resources that they may not have had before. Next slide, please. When every client comes to a PEP-V site, they receive a rapid COVID-19 test from Unity Healthcare, so Dr. Crosland and her team. And if the client is negative, then they are placed in a room. If the client is positive, they are then transported to an isolation and quarantine site where they can recover, and then they come back to a PEP-V site. Again, there are on-site medical and behavioral health services for clients. And again, this is not a substitute for lower Bay Area shelter. It's also not a substitute for respite care or nursing homes or assisted living, which PEP-V is also sometimes confused with. I will now hand the presentation over to my colleague, Bill Kennan, to talk about our vaccine distribution.
Thanks, Dina and Dr. Crosland, and good afternoon, everyone. I have the privilege to speak to you all a little bit about our DC vaccination efforts. And In DC, our DC health system reached out to us very early on to identify Unity as a partner for us to get vaccination resources out to our unsheltered and sheltered populations, our homeless populations, individuals experiencing homelessness. And so we quickly devised a plan and were able to, as Dr. Carlson mentioned, get multiple tents set up in various locations across the city to get vaccination resources out to folks, as well as to our unsheltered individuals. So I want to share some of the data that we have thus far, and this is as of the 1st of April. As of 1st of April, we've distributed 3,544 doses in total. About 791 individuals have received just the first dose thus far. 1,440 individuals are fully vaccinated, and everyone who has received at least one dose is 2,231 individuals. Of those, that breakdown of clients who have received at least one dose, 66% of those are clients and 34% are staff. And then individuals who have received their first dose in February, we've had 89% total of individuals who received their first dose in February return for their second dose. 86% of those individuals were clients and 96% were staff, which we are really excited about getting those first and second doses. And we've had access to the vaccine thus far until just recently. Next slide, Katie. Additionally, as of last week, we just opened up our access to our unsheltered population. We've been able to distribute approximately 300 doses of the Johnson & Johnson vaccine to our unsheltered population. To this point, we've just gotten access to the Johnson & Johnson vaccine, and we've been utilizing that to give to our unsheltered population as a result of the challenges that we face in the transient nature of our unsheltered population. Getting that access to individuals a second time was proved to be very hard, and we were able to get the access to the Johnson & Johnson, so we were able to distribute that. I'm also sharing some demographic information. However, as you can see in the unknowns, 37%, this is all self-report, and so this is the information that we receive from individuals, and if individuals provide no information, we don't have that information, but you can see the breakdown of African American, Black individuals, 57%, white, 4%, Asian, Hawaiian, Pacific Islander, American Indian, Alaska Native, just 1%, and then 37%. That information is unknown. To this point, we've had no wasted vaccine. We've utilized every dose that we've had, and we've had just 2 negative side effects in our population where individuals needed to end up in the hospital, unfortunately, but ultimately otherwise ended up okay. Next slide, Katie. Our vaccine rollouts. So during the month of February, the very first week of February, we started our distribution at our PEP-V sites, as Dina mentioned, our most vulnerable individuals. And then we went to our low barrier shelter programs, hypothermia shelters, and some of our adult and youth transitional programs. We essentially took stock of our complete universe of programs and looked at them. And obviously PEP-V was full of individuals who represented our most vulnerable population. So we wanted to get access to them as soon as possible. And then to our congregate facilities, our shared dorm style units, and then finally our apartment style units. We focused our initial efforts on our largest congregate facilities and worked our way through those programs, and then welcomed other programs as we were able to do so. And as we were able to be more successful and got better at the distribution and the collaboration and work with Dr. Carlson and our Unity team, we learned that we were able to incorporate more and more programs as we went on. So the intent was initially to vaccinate first doses solely in the month of February for 4 weeks, and then capture second doses throughout the month of March, and then do that again through April and May. What we were able to do, however, was vaccinate folks through the month of February, and then do second doses at our sites for the month of March, but also incorporate new first doses for individuals in previous programs who were interested in getting the vaccine now that they've seen others get the vaccine, as well as incorporate our youth, family, transitional, and DV programs in our rollout. Now for the month of April, we are vaccinating our unsheltered individuals for a couple weeks, And then we have a semi-fixed location where individuals throughout the month of April can come and get second doses that received first doses in March, as well as receive new first doses if they're interested in doing so. And we will continue to provide that single location to individuals to get first doses and complete second doses throughout the months of April and May. Next slide. What was really effective in our process was our engagement efforts. So early on in the process, we went to all of our hypothermia sites, our PEP-V sites, and our low barrier sites with Unity Healthcare to answer client questions and basically conduct town halls where we got information to our clients, dispelled rumors and myths related to the vaccine, and really answered as many questions as possible, particularly about the medical side of the vaccine, to ease concerns of individuals. We also then pre-registered individuals for events so that we had an idea of vaccine need at the different events. We then had provider calls where we met with our different providers at each of our locations to share additional information so they can translate that or share that information with their clients. We addressed misconceptions with their own staff so that they could share that information with the clients. We prepared them for vaccine events and the different information that they might need and for that purpose. And we discussed their roles in the process. We also created a peer educator program. This was for our COVID response in general to provide peers within our shelter system to be hired in short-term fashion to conduct and basically act as credible messengers to support communication efforts about COVID and eventually about our vaccine distribution to our individuals in our shelter programs. They conducted focus groups, and they ultimately have been really instrumental in encouraging individuals to participate in the vaccine distribution, as well as educating them about COVID guidelines that we have in our facilities. And then finally, we shared posters, flyers, and reminders to clients to be posted within the facilities to distribute amongst the larger community and make sure that there was no one left out as far as information as to where they can get access to the vaccine, as well as reminders to share for first dose, for second dose. We gave individuals lanyards where they could hold their vaccination cards so they wouldn't lose those and have them for the future, particularly our unsheltered population. So we did as much as we felt like we could do to try to get that information out to support the vaccination engagement efforts and make sure folks had information necessary to access the sites and locations that we were vaccinating at. And as I mentioned, to this point, we've been very proud of our efforts in getting the vaccine out to individuals, and we continue to have that success here.
Thank you, Bill. And now to finish this portion, I'm going to turn it over to Dr. Colette Harris to talk about her team's efforts in the field, doing these vaccine clinics and continuing to treat people experiencing homelessness during the pandemic. Dr. Harris?
Thanks, Katie, and thank y'all for having me today. I see that there are folks in the chat from Washington State. I was really excited because that's my home state. So I just want to emphasize that I think the reason why we had such a trust in our vaccination campaign is because of the continuity of care that we provided prior to the pandemic and during the pandemic. Like Dr. Crosland said, prior to the pandemic, we were providing outreach medical services to folks living in shelters and on the street. And in the beginning of the pandemic, we were out doing screenings at the shelters based on symptoms and referring anybody who had concerning symptoms for testing and isolation at the isolation and quarantine sites at the hotels. Then we began resuming our outreach medical services at a time when really there weren't many face-to-face services available because of the pandemic. Like people had limited transportation, limited access to specialty care, and we were there with people during that time. And throughout the entire pandemic, we were referring people to the Pandemic Emergency Response Program for medically vulnerable individuals, or PEP-V, and really advocating for their acceptance there. And, in flu season, we were implementing flu vaccine clinics at the shelters and for unsheltered folks as well. So when the time came for vaccination, we had already been there with people throughout the duration of this global pandemic. And like we've discussed, we did put on town halls at the different shelters. I also personally did town halls for the executive board at one of our shelters, as well as the Black Voices employee group at one of our food programs. And I think that I personally approached these town halls very much through a vaccine equity lens. And so I began by saying, I don't even like the term vaccine hesitancy, because I feel that that really misplaces the fault on the oppressed communities. And instead of the medical racism, instead of the fact that Western medicine, has been exploitative, has experimented on people, that it has been weaponized against people, and that any questions or concerns about the vaccine are really just a natural response to this colonial legacy. And that is that colonial legacy, that's the very system that caused these populations to be disproportionately harmed by the pandemic, to begin with. I think that during the town halls, we really discussed science behind how these vaccinations work. We really encourage people to speak with their doctors, to do research independently. I remember during one of the town halls, clients were taking notes and people were asking, how do I spell Moderna? How do I spell Pfizer? Because I really want to look this up later. I want to research this myself. And so we really tried to empower people to make informed decisions about their body and promote patient autonomy. And like Dr. Crosland said, we know these clients. And so we were able to talk about our personal experiences with the vaccine. And, when they come to get their vaccine, they see a face that they know that we are there to help them through the process. And so I think that it wouldn't have happened without being rooted in the trust that folks already had in the care we provide. And that's really all I have. These are just photos of the journey.
Thank you. I'm going to take a moment here. Thanks to all of our speakers, and we will open it up to everyone for questions. The first question that we received is, who is funding the ISAC and PEPV sites?
Sure, I can take that one. At this point, our ISAC and PEPV sites are funded by FEMA. And as far as we understand, the FEMA funding will continue until the end of this fiscal year, so September 30th of this year.
So now the PEPV sites were really innovative compared to, as Dr. Crosland mentioned, many cities and countries have, or cities and jurisdictions have done the isolation and quarantine hotels. The PEPV is really unique. What was the impetus? Who was the driving factor behind creating this? Where do you attribute that kind of gumption to make such an innovative idea go into effect?
I think it was a flurry of things happening at once. So our interagency council on homelessness thought about it. And then I think Dr. Crosland thought about it. And then I thought everyone had the same idea. And when we finally voiced it, it was like, okay, great. How do we do it? So I don't think it was ever a reason, it was never, should we do it? It was always how, because usually the logistics around things are what knocks us out. So we had to find appropriate hotels and be very clear about the criteria for those that would move into PEPV. What type of services clients at PEPV would receive? Are there instances where a person could be too sick to be at PEPV? So there were all these different things that we had to work out, but it was innovative. And I can't say enough how proud we are of this program because it was an on-the-ground, tangible, almost experiment of social and healthcare marrying.
Dr. Harris and Dr. Crosland, a question for you. What were the primary concerns that your clients had regarding the vaccine?
I'm happy to answer, and then would love to hear Dr. Harris's thoughts as well. So I would say the primary concern is what I hear from most people. How can we trust this? It was developed in such short time. I mean, everybody was saying this is kind of in record time, et cetera. So what got missed? Essentially, is it safe? So that was a number one concern, which I think is a very reasonable question. And the second was, will this give me coronavirus, which is something that we hear all the time with the flu. Oh, I took the flu shot and then I got the flu. And so really, as Dr. Harris said, listening to, recognizing the validity of people's concerns, and then citing the science, the evidence, and going through those things. So I think those are the two most common things that we heard and tried to address. Dr. Harris?
Yeah, I think people were very concerned about the side effects, like the immediate side effects, and also like what about the possibility of, side effects years from now that we didn't expect. I heard like, well, how do we know that this, isn't intended to harm us, coming from the government? Or like, how do we know that like the vaccine that, the healthcare workers that you got is like the vaccine that we're going to be getting? Like, what if we're getting a different one that's like going to cause us harm? And I think, in one of the town halls that I had done with the employees, a question was like, how they said, when people have, kind of like wild conspiracy theories about the vaccine, like how do you address that? And I think kind of so you don't have to say, well, that's irrational, or that's just a conspiracy theory, because that is all these concerns are very much rooted in reality, in history, and the present. And so instead of kind of like shutting people down and saying you're wrong, say, well, yes, that there are these injustices, that like the mechanism is a little different. Like right now, a great injustice is the equity of distribution of vaccines, for example. And so even though the mechanism of the, whatever theory may not be consistent with reality, it's definitely rooted in reality.
That's I was going to say the something that I would also talk to folks about is I would address this concept of health equity and injustices in the healthcare system, and how I was so grateful that DC was one of the few places that was prioritizing people experiencing homelessness for this limited resource, and that was, I think, an active choice of anti-racism, right? So it was acknowledging that, we in this country have huge problems historically, but also currently, in terms of providing good quality healthcare, access to healthcare to all populations, right? And I think that the two things that came up for me so fundamentally again and again during the pandemic were that housing is healthcare, and that the pandemic just crystallizes that so much. For those of us who've said that for years, it really has been an opportunity to kind of hold that up to the world, that not only for individuals, but for communities, that homelessness is a public health crisis, right? Not just for individuals experiencing homelessness, but for the whole community in the setting of an infectious disease. And the second thing is really, we have seen so publicly how disproportionately the pandemic has affected communities of color, especially Black and Brown communities. And so to speak to that honestly, and to say, this city has recognized that. And so we are getting this out to communities considered to be at highest risk. And so hopefully, with the trust that we've hopefully earned over time, that message will come through, as opposed to just sort of brushing it under the rug, as Dr. Harris said.
Thank you for that. A question for you, Bill. How has the use of data differed from past efforts, and what do you hope the DC does moving forward with utilizing data in such a wonderful way to track outcomes and really important measurements?
Well, I mean, obviously, we know the data can inform so many different decisions, and I think for us right now in our current operations, we remain steadfast in 24/7 operations with our low barrier shelter programs, and sort of continuing to limit the spread of COVID in our system. And so the more information we have related to who's getting access to the vaccine, and how much access, both through staffing as well as through client access, I think is going to help inform us a lot as to when and how we can open up our programs and what that's going to look like as far as sort of reopening services and access for our clients to our broader system of care. And so we have a long ways to go, but I think the information that we have now is going to certainly help inform what we want to do going forward. And I think additionally now too, just recognizing where our successes have been to further sort of support those successes, but also find those weaknesses and improve those opportunities to ensure that we're getting access to the right populations. We've seen lower interest with our youth. We've seen lower interest in our family programs. And so that's certainly going to help inform us in how we target those efforts as we go forward to try to get additional access to those populations.
Thank you for that. A question for all of you. What lessons learned would you recommend to other jurisdictions looking to create the successes you've had?
So,
How much time do we have? Okay. Do you want to start first, Dr. Carlson, and then I'll go?
Sure. I think sort of from the medical lens, I think that maybe a lot of the people on our kind of healthcare for the homeless folks, I think that really engaging with your local government partners is huge. And I feel like the first, 8 years of practicing medicine were really just reactive, and I was trying to figure out how to get insulin to my patient under the bridge. But I was just sort of beating my head against the wall for all of the challenges that I saw. But I think that really having partnerships with local government agencies gives you the voice and the tools to kind of create programs that are so fundamentally different and improve our patients' lives. I think that so that in terms of creating those programs, I think those relationships are key. So create them if they don't exist, and if they exist, leverage them, I would say. And then the second thing is for what we have done well and to sort of move forward with them, the PEPV sites for me really highlight how housing is healthcare. I feel like a broken record, but we have seen improvements in healthcare in our patients who are in these hotels. We've seen improvements in diabetes care, blood pressure control, HIV, et cetera. And I'm hoping that we can do some studies that actually show across the board some of those improvements in healthcare as a way to advocate for continued programs sort of along these lines. And then one final thing I will say is in terms of one of the successes, I know Dina said that this is not an alternative to medical respite, and we do have a lot of medical respite in DC. At the same time, we have found that there are a number of people in the PEPV hotels who are so medically vulnerable that they kind of meet that definition of medical respite. And so there's a sort of a subset of that group at the hotels that we've even labeled kind of medical respite because they're getting nursing care every single day, sometimes getting medications passed 2-3 times a day. And so we've almost doubled the number of medical respite beds in the city in that way. And hopefully we'll find permanent housing for those folks to move into. So, Tina.
So I think Dr. Carlson said mostly everything I was going to say. One thing I would add, though, that I think has been really, really helpful with this program is our ability to pivot quickly and to do rapid cycle evaluation. I think that the folks at DHS and the folks at Unity are really hardcore mission driven, which means that there was no such thing as a off the clock hour, which I think benefited our clients because the Pet V program is a 24-hour program. So when we saw trends and things, service delivery, hours on site, services, whether it be operational, medical, behavioral health, et cetera, we were able to change, shift, reshape in a way that benefited the client quickly. That's it.
Did you have to navigate any community opposition to your programs, like many communities across the country have to do? And if so, how did you overcome them? What were some strategies that you either learned from experience or had applied from past knowledge?
Go ahead, Bill. Did you want to start?
Well, I was going to jump in really quickly. Related to the vaccine rollout, I think one of the things DC does really well, and Unity does as well, like we tend to try to incorporate our community really effectively through our interagency council on homelessness. And so we have consumer groups and we have partners. And so we did a lot of that very early on, where we brought a lot of folks together and basically said, like, what do you need to see? Like what's going to make a difference? Where are we going to get these resources? And then we try to navigate and obviously meet those needs to the extent we're able to do so. Now, granted, we wanted to try to bring the vaccine out to individuals, like, at every encampment and to every person that, just drive around and do that. But the resources we had didn't allow us to do that. So we had to logistically like make adjustments, but we were in constant communication with our community about that. And so they were aware of the challenges. They were involved in the conversations and the planning, and at least related to all these other things that we do in the district. We continually involve that community. And obviously there's always folks who there's questions asked and there's pushback and other things. And, we're not perfect, but, we do our very best to try to incorporate and get that feedback early and upfront to ensure that the efforts that we're making are reflective of our community and the needs of the community.
Yeah. I think it's also important to note that we do what Bill was saying, we have standing ways of communicating out and collecting information in, and then we have ad hoc. So every week, when the pandemic was raging in DC, we had weekly partner calls that were open to a broad array of stakeholders. And we would, throughout the week, collect as much information as we could, try to anticipate questions we would receive, and organize our slide decks in a way that would answer the questions that we thought were on clients' minds, on stakeholders' minds. And then we will also leave time at the end for actually like rapid question and answer. Back and forth, we would log the question and try to answer, log the question, try to answer, so that we had transparency and really tried to push a broad-based, all hands-in approach to addressing the pandemic.
I would also say, when you're talking about the community, I think that we had the people on both sides. There was, I think, really only one incident of kind of NIMBYism that I can remember. It was one hotel in one particular neighborhood where we just got a lot of pushback for, why didn't you tell us? And, and this was an isolation and quarantine site where people were literally in their hotel rooms. They couldn't go anywhere for 10 to 14 days. And I have to say, I was really frustrated and disappointed with that incident. But for the most part, I think people, communities, the hotel partners have really been great. And if anything, the biggest kind of voice has been, can't you do this more? Why don't we have more of it? And so we grew from having one PEPV site to then a second hotel and then a third hotel. And along the way, as we learned from our partners, or not partners, but our colleagues in New York and Connecticut, who were doing double occupancy in the hotels, that they hadn't had significant outbreaks. And so we moved from single occupancy to double occupancy to sort of almost double the number of people that we could serve. And the residents in the hotels, there were some bumps along the way, but I think for the most part, people were really, recognized that this was a service that they were afforded a few months prior, and that it made sense to kind of give that opportunity to as many people as possible. So I think for the most part, the community has been very supportive of the programs.
I would be remiss not to ask this question, and I certainly will not end on a negative, but let's ask the the difficult question of what are the biggest challenges you are currently facing? I know we've referenced a lot that have happened over the past 14 months, but what would you say are the most pressing issues or challenge right now?
In relation to the vaccine rollout, I think probably one of our biggest challenges is continues to be the transient nature of our clients. And so particularly when we're doing first and second doses, we capture a large group of individuals and first doses, and then those individuals are no longer at our shelter, 4 weeks from now. And so we've been identifying all those individuals who are no longer there through bumps against like HMIS data. And then we are contacting every single individual that we have with phone numbers and email addresses to the extent that we have that, to try to encourage them to come back and participate. But, we don't get responses, we don't get that communication. So I know on that respect, we'd love to get 100% of second doses done. We've done pretty well thus far, but nonetheless, I know that's one of the barriers that we continue to try to sort of figure out. We offer transportation services, we have Lyft credits and Uber credits to get people back. So we try really hard to ensure folks have an access, a means of access to the vaccine. But I know that transient nature of folks from one program to another and leaving and transitioning and even going to like permanent supportive housing and other places, it's sometimes hard just to keep track of everyone. So we're really excited now that we have Johnson & Johnson resources to offer a single dose and hopefully capture more individuals where we don't need to get that second dose. But that continues to be a bit of a challenge for us.
I can say that.
Go ahead, Dina.
Another thing is that because there's uncertainty around how long the pandemic will last and when we should be in a response versus recovery stance for the pandemic, from a resource perspective, it's really difficult to understand how many staff we'll need, how much healthcare we'll need, how long should we have behavioral health specialists on site and ready to serve clients. So that's been a little challenging as we're trying to plan out. I think there was a question that I saw earlier about how we intend to use the new federal resources in the American Recovery Plan. I think we'll use some of those resources to help us look at next steps after Pet V, so that when folks leave, they're connected to some type of homeless intervention and hopefully not return to the street after staying at Pet V. Dr. Carlson?
I was just going to say, sort of wearing my advocacy hat, that not enough permanent supportive housing vouchers. The fact that homelessness, unfortunately, we don't have enough affordable and extremely affordable housing in DC. And if housing is healthcare and housing is the way that we would avoid this kind of disaster the next time around, I really hope that we can continue to push for and grow more housing opportunities for our clients. Yeah.
And Catherine, to pick up where you were just speaking, you spoke about good health outcomes. But one of the challenges nationally has been an increase in overdoses and mental health problems. How have you supported clients with behavioral health needs who are especially vulnerable? Talk a little bit about how DHS has also supported that effort.
Yeah, absolutely. So that's a great point. I think that was something that really took a lot of us by surprise. Not a little bit by surprise. We had this idea that we were protecting folks by putting them in a single hotel room to protect them from exposure to COVID, and ultimately when we had our first several deaths. The first several deaths, by the way, were not from overdoses. They were from complications due to poorly controlled diabetes. And so you have somebody who has poorly controlled medical condition, and all of a sudden they're behind a closed, locked door. And so if somebody falls out, rather than being in the shelter where there are 60 eyes on them, and somebody can call 911 immediately and get them the help that they need, this person is behind a closed door, and there could be several hours or an entire evening over which that person doesn't get the help that they need. And then in addition, we have had a number of overdoses, some of which unfortunately have resulted in deaths, many of which we've been able to intervene and get folks the help that they needed. But very quickly, we recognized the importance of having the behavioral health specialists on site. That was not originally part of the picture, but we quickly realized that having folks on site who were supported by an ACT team or a core service agency who didn't know where they were was a problem. And so making those connections and then bringing one of the core service agencies, MBI, on site 24/7 with behavioral health specialists, supporting folks, not only through what's a very difficult time to be in quarantine or isolation for 10 to 14 days in a hotel room, but also with substance use disorder and connecting folks to care, both their mental health care, but also all of our intakes from a medical perspective have been really to make sure that we look at folks' full medical picture. So we changed our intake form to really try to anticipate how people might get into trouble at the hotels. So every single intake, whether it's at the isolation and quarantine or the PEPV site, asks people, are you on dialysis? Because while not many people are on dialysis, those are the ones who get into trouble. If we don't know about it and then they miss a day or two of dialysis, that has been a problem. So we ask every single person, do you have kidney disease? Are you on dialysis? Do you have diabetes? Are you on insulin? And do you have your insulin with you? So right off the bat, we try to address the two biggest potential problems. And then we ask every single person about substance use disorder, alcohol use, both to anticipate potential withdrawal that could be deadly. And we refer folks to acute inpatient detox if we identify that as a potential risk. And people with opiate use disorder, we want to know about that so that we can make sure that people have access to Narcan. Having a roommate can help, obviously, if somebody has Narcan in their room and has an overdose. We have Suboxone prescribers on site so that we can get folks Suboxone to help them with any kind of withdrawal. And in some cases, we've been able to help people switch from heroin to Suboxone, which has been wonderful. And we also ask about nicotine replacement therapy. We offer that to every single person who comes on site to both kinds of hotels.
Excellent. All I'm envisioning there is that is an operationalized tool that will be essential when we get to the point where we start housing people without requiring a whole bunch of hoops before they get to the point of housing, because those are key factors that would be essential to know, but when we can just get to the point where we are just housing people. So one final question for you all is, going forward, what changes do you think will need to be made permanent?
So I'll just jump in again. I'm so sorry I'm talking so much. I'd love to hear other people's thoughts, but I think that this has forced a lot of us to really rethink emergency shelter. I am hoping that this opportunity to de-densify the shelters gives us the chance to think about how to maybe retrofit shelters to have, rather than folks being in large rooms, to have kind of smaller subsets, improved airflow, et cetera. But also maybe to think about alternatives to large congregate shelter, but rather non-congregate hotel-based shelter. I know I'm like going way rogue and I don't want my DHS colleagues to get mad at me, but I think that it's an opportunity for us to sort of recognize the dangers of large congregate shelter and to sort of think creatively about how to shelter folks in the future, as well as using the PEP-V sites as a model potentially for permanent supportive housing, site-based permanent supportive housing for older, medically vulnerable people experiencing homelessness, almost akin to assisted living, not as restrictive as a nursing home, but also with medical supports and maybe even meal supports in place, rather than everybody in scattered site housing with a home health aide. So those are some of the things that I would hope we could kind of carry forward.
Yeah, I agree. I think that just at a basic level, this public health emergency has been a forcing mechanism for different parts of a person's ecosystem to remove blinders. So now our housing providers, I think, are more aware of the behavioral health challenges our clients face, the medical challenges our clients face, because they now are in the same physical setting as a doctor who they hear talking with their client, or a behavioral they hear talking with their client. So I think that will carry forth as we continue homeless interventions with our clients, just an awareness of what our clients are facing. I also think that through this exercise on the medical side, I think Unity is very familiar with outreach, but I think that through this exercise, they now have a more robust view of all the different housing interventions that we have, from the light one-time funds that we can provide all the way to deep housing subsidies. So I hope that, after we are able to lift our heads and move back to some sense of normalcy, that we won't leave that integrative approach to delivering services to our clients.
What a great note. And I'm sorry to cut us short. This conversation is absolutely amazing. I am so grateful to you all, to Dr. Crosland and Dr. Harris, the amazing work you're doing at Unity. To Dina and Bill, you guys have been such phenomenal partners to learn about. DHS is really doing amazing work there. I want to thank you all for kicking off this series, and love getting the opportunity to highlight your amazing work. As I mentioned, this webinar is the first of a three-part series. So next week on the 13th, we'll be featuring Minnesota, a collaboration between the state and the Healthcare for the Homeless Project in Hennepin County. And on the 29th, we'll be featuring Chicago, Illinois, partnership between the city of Chicago, two Healthcare for the Homeless projects there, as well as a local shelter system. Then we also, in conjunction with this, we have a two-part series on trust and trustworthiness coming up on the 21st, followed by a session on the 28th. And then I want you all to know these amazing professionals have been fueling the information, the resources we share via our Flash Blast. So I encourage you to receive that bi-weekly newsletter. It is quick, it is concise, filled with recommendations and some validations on some of these issues that they are facing. Please join us on Monday, April 19th. It was referenced, the HRSA funding. We want to have some conversations about how the HRSA funding can be used, particularly with HUD funding, to be looking at partnerships like this and building them in your own neighborhood. And then finally, a plug, we are featuring the amazing work that is being done at these ISAC and PEP-V facilities, and featuring the staff of Unity and DHS at our national conference, which will be virtual this year. The whole symposium goes from May 10th through 14th, and we'll be featuring this as our site visit, actually. So you'll get an opportunity to have some video tours of that. So a little teaser to get to spend some time with these individuals again. Thank you all so much for your time, for being with us. I wish you all a safe and wonderful afternoon. And again, thank you so much to our speakers. Have a great afternoon, everyone.
Thanks all.